Scott County, providing safe, healthy, and livable communities.
Number 6.1, receive information on Scott County Delivers topic, children's mental health. And Chris Harder, take it away. Oh, I mean, wait a minute. Chris, you looking for an IM here, and I don't have IM. Katie Maleka, welcome. Take it away. Nice to see you this morning.
Same for you. Good morning, Commissioners, Mr. Chair. Today we're going to spend a little bit of time speaking with you about children's mental health. For more than a decade, this has been a priority of the board, specifically preventive work to avoid the need for deep end services. Progress continues to be made in this regard. Today you're going to hear about the build-out of a continuum of care provided by the community and by the board, by the county. We have a distinguished panel here to speak with you today to speak to the specifics to children. This expansion in the continuum of care includes increased services provided within the mental health center, including the mental health center as a certified community behavioral health clinic, coordinated response, and school-based services. While the continuum of care continues to be built out and gaps are filled, we are aware that some gaps continue to be present. We look to the future as a new behavioral health clinic is being built. With that, I will ask our facilitators to introduce themselves, and then I'll ask the presenters to introduce them. Please state who you are and what department you work for.
Good morning, Commissioners. Jen Schultz, Scott County Library Director.
Adam Jessen, Transportation Services.
Jake Grusing, Transformation Enterprise Services.
Good morning, I'm Steve Brown with Social Services. I supervise children's mental health, chemical dependency, and our truancy program.
Morning, Christina Scalzo, Children's Mental Health Case Manager.
Ryan Lager, Superintendent, Belle Plaine Public Schools.
Good morning, I'm James Holden. I'm a supervisor at the Mental Health Center here.
Good morning, I'm Jen Peterson. I'm with the Coordinated Response Program.
Hi there, I'm Tanya Ward. I'm Director of Behavioral Health and Housing here. And this is the panel that worked on this packet here, but I also want to thank Mohammed behind us, Katie and Evan who helped with data behind the scenes.
Thank you all for being here today. And with that, we'll have Jen with her first question.
Thank you. Well, first of all, I just want to start this by thanking you all for being here. I have actually been here for over a decade and seen the build-out of mental health services in general, and the packet was impressive. So thank you for all the work that you do every day for kids and families. With that, I wanted to start with our community indicator on page 8. Which really talks about the proportion of the population per the one mental health professional. And so I have a couple of questions here, and I'm not sure who wants to take this, so whoever wants to take this, maybe this is yours, Dr. Ward. I suspect that the data is telling us the mental health, like for kids and adults. So my first question was, do we have any information related to the proportion of practitioners related to children's mental health or working with kids, or do we not have that data? And then the second question that I have relates around what appears to be an increase in practitioners, which of course is good. But then going back to page 6 of the data where it talks about your gaps, clearly there's still some needs there. And so I'm just wondering if you can kind of align that for us about, yep, we're increasing practitioners, but we still have some of these needs which are likely maybe in some of those specialized areas, but wanted to give you an opportunity to talk about that.
And the rest of the panel, feel free to jump in. Yes, you are seeing that there are more individuals entering the field of mental health to become professionals, which is a great thing. I think the need has skyrocketed as well, which has not kept up with the pace, which is probably why you see we still have a gap and shortage, but we're also seeing an increase. And similar to what we said in the adult services presentation, that this is the amount of professionals, but it doesn't separate out folks who are involved in crisis work or maybe that more intensive work, which that's where we're really seeing quite a bit of a shortage, and that's for both adults and children. So I just want to point that out, that while it is going up, we will still continue to see that those higher deeper end services, that's a need. I think folks just, they really like their outpatient work where they meet once a week with a client. It's steady, it's stable. The more intensive work it's a little tougher. It's more coordination. You see more significant symptomology. James can probably talk about day treatment and in that regard. And then your other question was about, can this you separate it out between those who serve children and adults? At this point, there's no way to tally that. I think folks are drawn, and maybe the folks who work with kids can speak why they work with kids. I know they enjoy systems work, so when you work with a child, you work with their family, you work with their teachers, you work with, and we'll speak about more of that today. So I think just folks are drawn to that differently in terms of how they conceptualize the mental health of a person, in terms of if they want to work with adults or children. Does anyone want to speak to that?
And it's not uncommon for a mental health professional to work with both. So I think that data would be really difficult to pull out. So if you're working with children, you might also do marriage therapy, you might do family therapy, you might do adults as well. So,
and I would say the vast majority of the children that we worked with were also doing family work, parental kind of work, those sorts of things. So in terms of like somebody specifying their caseload to adults only, that's going to be a difficult number to identify because there's just so much integration, especially when you're working with youth. You really can't treat the youth without treating the family system and the adults that are working with that person too.
So I'm looking at page 14. It shows data about school-based clients and their improvement. Just looking at that chart, obviously it looks like a lot of success there. In the last 10 years, the percent that are showing improvement is over 80%. So I'm wondering if there are best practices or learnings from the school setting that potentially could be applied to other settings.
I guess I'll probably take this one. One thing I often say is I think mental health has become the biggest challenge that we face in schools right now. We have a lot of kids who need mental health support. And we often talk about, or try to discover why that is. And one of the things, at least in Belle Plaine, that we made a movement towards about 6 or 7 years ago now is we have a daily component. It started at a 7-12 level with a program called Move This World, where kids, for 5 minutes at the start of the day, watched kind of a video. They practiced breathing techniques, but they also shared with kids what it was like to feel anxiety, what it was like to feel or depression, what it's like to feel loss. And I think that by introducing those concepts, and because I think sometimes kids are struggling and they don't know what it is. They don't know that I'm depressed. They don't know that I'm anxious. They don't know that I'm dealing with grief. And sometimes we think of grief and loss just as if somebody were to pass away or things like that. But there's grief and loss in a lot of other ways that kids struggle with. It could be loss of a friend or a friendship that they think that they had that dissolved or for whatever reason fell apart. And we learned a lot of that through that. But what we learned is the more we taught kids these things, then they realized they had something that they needed help with. I'm depressed. I have anxiety. So now they would go somewhere, and we didn't necessarily have what I would call a systemic solution in place. So out of that, we've really built a strong systemic response. And what that started is, okay, well, now we need to have, a counselor, social worker in each of our buildings. So now we've told the kids, here's what you're feeling, here's where you go to get help. But then what we found from our guidance counselors, social workers is, we're trained at a certain level to do this, but school counseling isn't therapy level counseling. And they were like, now where do we go? So a few years ago then, to add to that systemic approach, we went from doing something every day to providing that counseling service, but then to freeing up our counselors by adding a full-time mental health therapist. And I think we're at about 1.75 right now, and I'm trying to get an additional, because we need an additional 1.0. We have, my fear is we can't have kids on a waiting list. We've done this work to help them identify that they're depressed, they have anxiety, they're struggling with these things. We have to get them the support. But in that, so the next step of that systemic process was to give them mental health therapy at school, because a lot of these kids, they can't drive to Shakopee, they can't drive to New Prague, they can't get to Waconia to get to places because we don't have therapy level services in Belle Plaine. But then from there, what we realized is even in maybe 3 days a week of meeting with a mental health therapist, some of these kids needed day treatment. And that's when Reflections at Southwest Metro became a part of that. So we have a very systemic process where we every day, and this is part of what we've come to, is maybe we're doing a better job of helping educate kids about mental health challenges, and when they feel certain things, it's okay, and here's what they are, and then here's the process that you walk through. I would say, I think the piece that, and I think you said building a clinic, the thing we've talked about that we need more of is that residential treatment, because we have kids who get to reflections and are getting day treatment and they're there, and then eventually they come back to school, but they need another level of care. They're not even ready to come back at that point. So I think that residential treatment piece is going to be huge, because unfortunately we also have a need for that.
This is another question. I'll direct it right at you, Dr. Lager.
I've already talked. I try not to talk too much in these things.
That's good. And you talked a little bit about the systems of support for students and where our therapists, school-based therapists, fit into that. How, from the district standpoint, do you integrate those school-based therapists into the rest of the systems of support? Are they working just with the students, or do they have interactions with teachers, with administration? Just give us a picture of that, please.
Right now, from a service standpoint, they only work with our students, but they work very closely. I will say that the thing that I think has been powerful is, as adults, especially who are attracted to working in schools, we want to help and fix all kids' problems. And our guidance counselors or social workers went to school for that training, and I think they were struggling with, I really need to help this kid. And then they would look at a kid and say, I need to find a way to get them therapy, but they can't get them to the appointment. So having that mental health therapist in school on site, I just had this conversation with the district in the Metro last night, on how we need to change how we staff. Like, we've always had positions in schools. Maybe instead of having as many guidance counselors, we need to add a mental health therapist in the school setting, because parents and families aren't always willing to go to a clinic to get the help. But if they can go somewhere on site where someone's there, they're much more willing to access it. And personally, I think we're seeing a lot more success because they're there each day. But administrators and teachers would make that, or counselors make the recommendation to get them there, but they aren't servicing adults in terms of with their own mental health challenges.
James,
If I
do
can-
you want to? Oh, okay.
Yeah. If I can add just a little bit, if that's okay. The therapists really aim to do a lot of collaboration with the social workers and guidance counselors and teachers as well. We also provide trainings to a lot of districts throughout the county. I know we've done some out there in the past. I don't know if we've done recently or not necessarily, but in fact, today I'm going out to New Prague to do 2 of them after we're done here. So there's other ways that we really try and integrate, but I think you're exactly right. The need and the demand is so high right now that we try and prioritize those caseloads as much as we can. I think one of the challenges with serving students in school districts, in addition to kind of that need, is finding qualified therapists to work in those settings. That's been a challenge for us over the past year. We've had open positions and we've filled them with the best people that we possibly can, obviously, but making sure that we're picking the right people for the right districts that are going to be a good match for them is a priority as well.
And that there's consistency. The ones we have now are phenomenal, and they're valued. Like, our staff love that. Like, they're integrated in with our staff. We had a period of time there where there was a lot of turnover, and that can be hard when people don't stay in the role for a while. But the people we have now are absolutely phenomenal.
So that's the district side, right? From a county side, flip that question on its head. How are those school-based mental health workers integrated into our side of things?
Into the county, you mean, or into the, okay.
Yeah, into the county. So as their employer, they're out there. I think I've heard they're sort of a satellite clinic on their own, the folks we have embedded in the buildings across the county. But how are they integrated into our systems here?
Yeah, so on a really basic level, they're still a part of our staff. Obviously, we have our weekly meetings. We do supervision with them weekly, but we really try and focus on collaborating when we have opportunities within the group consults on Wednesday mornings that we do. We have a full consult on the first Wednesday of every month, and then we have separated ones, so people who are satellite or people who want to join virtually do that. That's been a change since probably COVID, I would guess. That range in our team has gotten so big that it's really hard to do good collaboration with too big of a group. And so that's one of the ways that we bring them in.
And I think the folks who are the therapists who are in the schools will say they have 2 teams. They have their school team that Dr. Lager spoke about, that integration, and then they have their county team. And I think by nature, when they're in the schools, they're used to collaboration because they really can't do their job unless they have that lens of if I don't get everyone on the same page, how are we going to help this child's life better? And so I think by nature they are actually really good at the collaborating piece, and I think the case managers could speak to that. That doesn't matter if they're at the school, if they're primarily located at the clinic, if they're out at the JAF. That's the first thing I think any person who specializes in working with children looks at, or who are the people I need to know who's involved in this child's life, and that's part of the assessment process. And if they have a case manager and the client permits us to, signs a release of information, that case manager is definitely part of the team and part of the treatment. I don't know if you guys wanted to add anything, Christina, from what you're seeing.
Well, I was just going to say another way, like we often get referrals from the school-based therapist saying this kid needs more support than this outpatient, school-based therapy. So then we'll get those referrals from the Connect therapists and get involved that way.
So just sticking on kids for short more time on the school-based stuff. Looking at 14 obviously speaks to the GAF scores, and it looks like, so if you look back to how many kids you're serving, then how many kids are getting GAF scores, obviously I'm assuming not everybody's getting a GAF score because those numbers don't match, and it speaks to the longer term services. Can you just speak a little bit about the different services that are happening in the school in terms of the longer based services, and again a little bit about which kids are getting this GAF score that we can measure, and then those other kids that maybe aren't necessarily going through that?
Yes. So in terms of the model that we provide in the school system, it is a more it's a longer model because we want to make sure we're providing the same treatment that they would get in the school that they're going to get in an outpatient clinic. Other models do exist. We find that this works really, really well with kids in the long run. One of the, I won't say it's a challenge, but one of the things with that, I guess is how I would say it, is it's going to be longer term for some of those kids that really, really need it. So the number of GAF scores might fluctuate depending upon how symptomatic kids are, how long, and because the level of their symptoms, so how severe their symptoms are, is going to be correlated with usually how long they're in treatment. So the number of GAFs that we run on a year are based on when somebody starts and when somebody finishes. And so if we have some kids that happen to be there, or a group of kids that happen to be there significantly longer, just because of how symptomatic they are from when they start, it's going to decrease our total number of GAF scores on any given time period.
So do some of those kids go year after year, they stay year after year, and then what happens in the summertime for those kids? They continue?
Yep, we continue to provide services throughout the summer. Sometimes, depending upon the age and developmental stage they're in, sometimes they transition into virtual appointments. We continue to see them within the school buildings. If that's an issue for some places, then we offer opportunities to see them here in the mental health center if they can get transportation. A lot of our case managers do a great job of helping kids continue to access services throughout the summer as well. If they need a ride, like for Reflections, for example, our day treatment program, we've had many case managers pick up that gap or close that gap and say, let's get the kid there. They need the service. Let's figure this out. We'll work together as a team and figure out how we can continue to serve through our whole continuum of services.
And the schools are great partners in the summer. They allow us into their buildings. And so, if a kiddo typically attends a high school, but during the summer, let's say they physically are closer to one of the elementary schools, the schools allow our staff to rotate in those buildings and build the caseload and see kids in like whatever location is most convenient for them.
All right, I'm looking at page 11. And we're looking at a graph that shows the children in out-of-home placement over time. And just visually looking at this graph, you see kind of a roller coaster going on. High number of children in out-of-home placement in the 07-08 time frame, and then dropping down 13-14, and then back up in 17-18, and currently more down on the downswing. So, what kind of knowledge do we have about the cause for that, and how that we look to the future to try to prevent another upswing in that data so that we don't repeat that same trend?
This graph will represent all children in placement, shelter placement, short-term placement, as well as children's mental health placements. So the number of children's mental health placements is very, very slow. So I can't speak to the larger numbers, but I can speak to children's mental health. Those numbers are pretty consistently low over the course of time, year after year, which we're proud of. So we should have actually had a individual graph just for our residential treatment placements. Sure. Currently, I think we probably have 3 in placement for treatment purposes.
I think a lot of the reasoning for that is clinically based, right? That we know kids do better if we can work with the system that they live in to help improve the system that they come from. That's where the outcomes really come from. And the services, the mental health services provided in a residential setting are really not any more than the intervention that's provided like in a day treatment setting or something like that. You're adding the safety component is what you're really doing when you look at a residential placement.
Correct.
And I'll just speak from the coordinated response lens. I feel like that's a really big part of what our, purpose and mission is. We really try to get involved. We're getting referrals from law enforcement, and a lot of these families are just really pushed to the max. And the things that they have tried or the strategies that they have used are not really effective anymore. And maybe they just don't have the resources in place, and we're really bridging and linking people to those resources. So I think we're really coming in at a crucial time during that crisis stabilization and kind of getting them back in a direction. And I feel like that early intervention can be a big part of that too.
And I think we're really grateful for that opportunity. It might be the first time. It is stressful and scary for the family, of course, to have law enforcement and then be referred to coordinated response, but it might be the first time anyone said anything about mental health to them. And I think the coordinated responders do such a great job of explaining it, normalizing it. And so that may be the first time we see the child and we find out that the child has suffered from PTSD for 5 years. And then when we can explain to the parent, maybe this is why you're seeing, his grades go down, or maybe this is what we're seeing. It's actually really helpful, and we see that as just a door into service.
I'm going to try to ask this question in a way that will land as fair to the folks on that side of the table. So what I hear from Jen with coordinated response is that we think, and correct me if I'm wrong, that some of the coordinated response work may be preventing some of those out-of-home placements, that those numbers may be going down because of the work you're doing. So I had just 2 questions. One, what do we think with it? If it's children's mental health case management or it's the coordinated response, what do we think about the impact of those programs from a prevention standpoint when we look at the out-of-home placement? And then what do we know? If there's something we know that we can say definitively, we're preventing those, please speak to that too.
Well, that's a big question. I think it's pretty impressive. Scott County consistently over, I can say, the decades has a strong placement philosophy that family preservation, kids are best served in their own home. If they can get the services and the treatment in the community. And so then if we get a recommendation for residential treatment, which we get a lot of recommendations for residential treatment, we don't say, okay, let's put the kid in residential treatment. We ask a lot of questions in terms of what's going well. I mean, I think the one thing that we do really well in children's mental health and across the county is like, how is the child functional? What are their abilities? What is their connection to family? Do they have other connections? How are they doing in school? Is school going well? And if we place them in residential treatment, what's the experience that is going to be on that child? What we do know about the long-term outcomes of residential treatment is they don't last. And so if we're going to invest that highly into something, we would want to see some evidence that it's going to be a positive experience. What we found is I can let Christina speak to this. We've had some extremely challenging, difficult, high-end children in the home that we serve. And that is when you look at across the panel, that's, I think, where that collaboration is extremely important. working with the family, supporting the family so they have the resources, they have the needs. We're doing assessments in terms of are there other more intensive services that they can receive in the home. Can we coordinate with the school? Do they need more school support? Are they short of just material needs? Are they have food insecurity, housing? Do they have multiple contacts with law enforcement? A lot of these families have toxic stress, and so supporting the family. If the family's not well, you're going to have a difficult time getting the child well. Sending the child to residential treatment isn't going to support the family in that way. So I can say we focus very intently on that. That is our goal. That's our philosophy. Those are expectations. And there are times that we make that, but I think James referred to that. It's typically for safety purposes. So if you need containment, if the child is a danger to himself or others, and the family cannot manage them in their own home, there's a place for that. And we've done that before. But we will ask the hard questions. We'll have the hard conversations with the hospitals and those making those recommendations. And we do a lot of education and support to the families to help them understand their diagnosis, how they can make improvements in the home. You want to add to that? I mean, it's hard work. It's really hard work. I mean, there's lots of pushback from lots of different ways.
I think a big piece is educating parents and the community. Sending a kid to residential treatment doesn't fix the kid, like we talked about at the beginning. Like the kids are part of a family system, part of a community, and so oftentimes when we get those recommendations or those asks from a family, my kid needs residential treatment, like it's really digging into what's your best hope with residential treatment, really what are the concerns, and is there a better way to address those? Because we don't have enough information to say residential treatment is a solution in these cases. Residential treatment is really used for containment, for stability, for safety, short term. We still have to do all the other hard work in this residential program as well as outside of the program to have this kid successfully transition back to their family and community.
I think anecdotally, day treatment, I would say, is a big diversion from residential. Many referrals come to day treatment that literally say, it's this or residential. So we're trying day treatment first, and they don't end up going to residential. Because like James said, it's the same amount of clinical service. It's like 14 to 17 hours per week of therapy these kids are getting in a school environment. So we're able to help them with group and individual therapy and lots of family therapy. They learn the skills. They're able to then practice them in the school setting with teachers, find what works, doesn't work for them, and then they can go back to their home district school, like in Belle Plaine, and then they can practice those skills that they learned at day treatment. And then they feel success. For one of the first moments in their life, they feel successful.
One of the things, and I say this a lot too, I've worked in 3 metro counties. And the one thing, and you said earlier that Scott County has a rich history of this. The other thing is I'll just say that you do it right, because I feel like there's great partnerships in this county. And what I mean by that is we had mental health support for kids when I was in a county on the east side of the metro, and we had mental health support when I was in a county on the north side of the metro. But the problem is their support services all were in buildings that were off-site. And just a simple partnership of being able to put mental health therapists in a school setting seems like a small decision that is an absolute game changer, I think, for what you're talking about. Because I think if kids can get that support each day at school, or 3 days a week at school, or 2 days a week, in many cases, that's the help they need. But if it's dependent on them getting 8 miles over to another building where all the therapists are, they don't go. And then they spiral and they spiral and they spiral, and it gets worse. And now they end up in a situation like this, because it is for containment and that, but the situation gets so bad because they don't get the skills and feel the success in that. So it's just a credit to the county. This is just one area where I feel like there's a lot of, we talk about partnership, but you don't see it come to life. I've seen it really come to life, not only in mental health, but in other areas that we're able to partner with the county. The other piece is how we pay for it, like the way that we've partnered with the county. And I'm the first to say, I don't know who to hire as a mental health therapist. So I came to Terry Raditz at the time and said, I need a mental health therapist, but you guys interview and hire because she knew what we needed. I have no idea what I would be looking for. And that's why we also have great people. So it's little decisions like that that are made because there truly is a desire to partner. It's not just one entity trying to do to the other entity, which often happens. So
I also think a part of the answer to your question, both kind of sides of it, is just how much across the continuum of care that we provide, how many services are truly available within one institution. So it's really easy for us to be able to collaborate internally as well as then reach out to our community partners. And I think that creates a safety net for kids that's really, really important. And I think adults as well, not just kids, but I know we're focusing on that right now. So that creates a safety net that we can really catch people in and try and prevent them from and help guide them really to what is the appropriate service, what is the appropriate intervention, what do we have for you right here already built, and how can we rely on other kind of, I don't know, other strings in that net or whatever you want to call it, to be able to provide some safety, comfort, support across the whole continuum of mental health services in our area.
Going back to Dr. Ward's comment about every door, if we look at page 16, this refers to our coordinated response referrals. Jen, if you could talk to us a little bit, if we have any thought or ideas or information about how many are first time versus repeat referrals, and then what does that tell us about the work that you do?
So we have, let's see, we have about average 100 referrals that are in 2023 and 2024 that are just one-time referrals. So that is not repeat referrals. I believe when I looked at this graph, it was about 177 total in 2023. So yes, we do get repeat referrals, but there's a lot of need. Quite frankly, I don't think we realized that we would be getting referrals on kids when we started, and we really had to adapt and adjust, and so I was put on responding to those referrals. In terms of the work, I think it shows that there's a lot of need for families to have the support, and they really don't know what to do when we show up. They're in crisis, and we're giving them that direction. So, yeah.
In 2024, 99 children and families were served. Again, I think it speaks to the need, but it also, I think we're grateful for that, because again, I don't know how many of those 99 have never interfaced with a mental health professional, but it could be a fair amount, and for them to have, we have them on our clinical radar, and being able to, the things listed on page 3, de-escalate what brought them to coordinated response in the beginning. And Jen goes out there multiple times. This isn't a one-time thing. She may be working with a family for months, getting them to a place to see maybe the clinical issues, and then bringing them to long-term services, bridging that gap.
I think that's really important work, because that's you talked about gatekeeping. That's also the initial phase of treatment for a family, right? Is being able to connect with them, being able to go into the home, being able to be there with them, and really you're starting the intervention then. And hopefully through that experience for them, they can start to reach out for what else might be helpful as you start to explore what services could be beneficial to them. They've had a great first encounter, great first experience, maybe a little bit scary at first, but look at how it turned out, and now I have some trust that I'm going to be able to find some services elsewhere as well.
And if you turn back time, back in the day when law enforcement would get involved, we used to hear the only way we could figure out how to get them the support they need is to put them on a 72-hour hold and put them in JAF in a placement, and then the county would have to respond. So we've come a long ways from then.
Just a kind of a clarifying question, Jen. Is some of the data, the adult and child data, is that ever a situation where you end up giving services to the adult and to the child, and it's really a family situation? Is that some of the data here, or are these really, they don't overlap at all?
Correct. It's based on who law enforcement puts on the referral as the identifying client. So if it was the child that was the focus, that's how it gets counted. If it was, so it's really based on how the law enforcement referred that. Sometimes we say, let's make a referral for both, because the parent might need some support. So if that's the case, then that's an adult referral.
It's clinical judgment, because you never know until you get into the system what you're seeing.
Mm-hmm.
Do you see that happening frequently, or is that kind of the exception?
I would maybe the exception. I think I get the referral and then I run with it, right? I look at, when I see that it's a child referral, it's the family as my lens that I'm working with.
On page 13, we have the topic of MnChoice assessments. Obviously, there's a very lofty target goal there. Do we feel that there are impacts to mental health outcomes of not achieving this goal, and maybe some impacts on our other KPIs that are part of this packet?
We went through with MnChoices, and we, somewhere in the narrative, I have to find it, we wrote about, oh, here we go. In 2023, 83 is on page 6. 83 of the MnChoice assessments were completed on persons 0 to 17, and then in 24, 188 were completed on children. Someone in the audience who knows more about MnChoices want to share about the impact and how?
Rush.
I'm phoning a friend.
So MnChoices becomes the way in for families or children to access specialized services to help meet identified mental health needs. What I can say is there's been lots of MnChoices discussions in terms of being able to move people through annual assessments. You heard in the beginning with Mayor Briggs and the work being done at the federal level, as well as legislative work here at the state. What I can say in terms of impact, this is, I think, the beauty of Scott County in terms of the collaboration. So there's certainly wait lists for people to get in and access a MnChoices assessment, which then opens up the gate to additional services. But if and when we have a young person who's really demonstrating high need or really complex behavioral challenges, and there's a need for intensity of resources because we see placement as sort of the potential next step, this team of people and our MnChoices staff really work together to prioritize an assessment to be able then to see what additional services are needed so we can avoid either the placement altogether or we have different funding resources to help identify specialized treatment.
I think one other piece to add to this is some of us have heard about a bill that is in relation to with MnChoices and kids that are needing hospital level of care in counties that could potentially get charged $250 a day for every day past the 20 days waiting on this. And because of the prioritization and the working together that Suzanne just talked about, our average wait time is only 8 days, because we try to prioritize those kids. So it's just an example of like the urgency that we feel when working with kids with mental health issues and wanting to support that.
Thank you, everybody. With respect to time, I want to ensure that our commissioners have time for questions. So thank you for everything, and I'll turn it over to Mr. Chair and the board.
Thank you very much. Members, any questions you want to start out with?
Thank you.
I figured
Thank
I'd look
you.
to my right. I figured probably, maybe.
Yeah, maybe. Well, thanks everybody for the panel, for the discussion. Just want to level set for a minute about, because we have so many guests in the room and hopefully many more online. Of course, children's mental health and addressing it is one of our mandated roles. Now, counties do that differently. We figure out what that program looks like, but it is mandated. So some people are like, what are we talking about this for? One thing I want to ask, and maybe Steve, you're the right person for this, but I think in the past few years we've made some additional investment into children's mental health, maybe with some ARPA dollars. How has that impacted our whole initiative in this area? Is it case management, wait times, wait list? How have those additional resources made a difference?
Suzanne can help me out with that as well, but we've been able to, prior to that, it's related to caseload size, and so having a large number of referrals and those open to case management spread between, let's say, 5 case managers, the standard caseload size requirement is 15 for DHS. And nowadays 15 is, you can say, pretty active. Our caseloads were probably pushing 18, 20, and over 20. And so we've been able to allocate another case manager to that and reduce our caseload size, and now it's much more manageable. So, it's just simple math. The more time you have to spend with families, the more you can get to know them, understand their needs, and employ resources needed to help them.
Wonderful, thank you. I just thought that was good for us to know. Second question, Dr. Lager, thanks for being here. Thanks for your partnership as always. And I think you fully answered this question already, but I want to give you the opportunity to say any more about it. I think for our colleagues around the state, sometimes counties collaborate and invest in mental health professionals in the schools. Sometimes they just say, schools, you apply for that funding, those grants, do it on your own. I think you spoke to why you think this is the right plan. I just wanted to give you a chance to add anything to that, because I think that's sometimes a decision we have to make. Should the county be involved in getting these professionals to the schools? Is that the right way to do it? Any more you'd like to say about that?
Well, I think just in speaking from Scott Family Net, which we meet, Scale, many of my colleagues as superintendents go to as well. I think if the rest of the superintendents in the county were sitting here, they would tell you that mental health of our kids is something we're all extremely concerned about. And I think they all would also tell you that the ability to have therapy level support, the Connect therapists in our buildings, is the best approach. And I know many of them have been superintendents even out of the state of Minnesota or in different, again, counties. And I've had conversations with them individually about just how well this system works. And I think the thing I constantly reflect on is it's such an easy thing to do, but in other places I've been, it's just not that easy to do it, kind of because what you've said is either we don't want to do anything with it, or we have the money, so we want to run the program, we want the employees, instead of really looking at how does it best work for the kids in the school. So just thank you and the people here, however that all got organized and continues. It's every time we call and ask for additional support or help, it's a problem-solving approach. It's not we can't do that. So thank you for that.
Thank you. Thank you.
Thank you very much. Any other questions? So I've got a couple questions. On page 2, it's kind of our continuum of care of sorts. And sounds like, and certainly feels like, and again, these are overgeneralizations, but we have a pretty robust continuum of care. Also some gaps, right? Also some gaps. I mean, so you look at the continuum of care on 2, and then so we always fashion these like what's going well, what's not going well, and so under the challenges, school partners for one question. Item number 2 under challenges: school partners indicate that mental health needs are more significant and are starting earlier in a child's life. So one question is, who are those school partners? Like who fits into that category? Is that third-party folks? Is that us? Is it you? Is it?
Well, one of the things I haven't talked about specifically today is we also saw a significant need in the earlier part. We actually just opened I'm going to say K-5 elementary program through Southwest Metro, which is in Scott County, but we bought a building in a neighboring county, and because the facility was available, but we started a full-time day treatment program for kids K-5, and I will tell you that that's something that people go, are you serious? You know, really, like we're sending, and I personally have, from Belle Plaine, have had kids that have had to go to that program because they need that level of care for, I mean, we say containment in that, and some of it is already at that level of containment. And I should know this, but I know when we were looking at doing this, one of the hangups was it was so easy working with Scott County to get the mental health therapists in. But this was in another county. But I wonder if we didn't solve that. I was going to say, I think we actually have Scott County people working in a building that's located in Carver County, because that's where Southwest Metro was able to purchase the facility. So again, that's just another example of the biggest hangup was we didn't have a partner over there that was going to put the therapist there. But again, people here found a way to make it work. And
it's
that's
an expansion of Reflections.
Yeah, it's an expansion. Yeah, to elementary kids. And we're in year 2, year 1, 2?
1.
Year 1. We're in year 1 of that.
April 1st of last year.
We've been talking about it for a few years, so I don't know how long it's been up, but yes, it's starting earlier. And again, that next step in that systemic approach is we need day treatment for those elementary kids.
Well, I mean, our perspective has always been, and it's been mentioned here too, is sure, I do feel like we've got a very robust continuum of care, but there's gaps. But also, we're not looking to recreate the wheel. If there's I mean, these are statewide issues, right? So whatever we can do that Carver County doesn't need their own, we don't need their own, Dakota County, like kind of in the soup together, we could pool things together and do it more efficiently with the hope, with less money and better outcomes. That's what I'm always about, is the better outcomes. So you don't need to whisper Carver County.
I don't want to call out the other counties.
Team. Well, that was part of the question. School partners. I mean, we're all involved in that. And so, going back to that again, page 2, continuum of care, and then also going back to the challenges. The schooling services in high demand. We need more of this and that. So how do we? And again, I don't mean to make this sound undermining, because it is not in the least. But what do we do? The need is there, right? We have the need. Need's probably going to be there for the foreseeable future, right? It doesn't mean we aren't about better outcomes, because we are. How do you triage some of these things where it may be, deep end services? I get that's probably a completely different category versus, this is just a series of bad choices that led to a down day, and it's not like this. I got this mental health hammer, so everything looks like a nail, versus like, hey, maybe a different choice. And again, I don't mean to oversimplify, but when the need is so great, the resources are less than that. How do we do that? And that's where I was going back with the partners. Are there partners that we work with on some of those touch points, or even that deeper end, that can help better outcomes, more efficient, and not just government?
I think the school is probably our biggest partner when we have these conversations. When we think about triaging kids, and I agree, it's really important to look at what they need and to meet the level of service. It's a risk to over-pathologize anyone. I think it's a bigger risk to over-pathologize children. Those labels stay with them. And it can impact them if it's not done appropriately. So a diagnostic assessment is really, really, really important, and that's part of the reason why James will say we do hundreds of interviews to find somebody who really understands children and understands through that lens. That's why Jen is really good at what she does, because she knows that what is normative behavior for a 12-year-old versus what is mental illness in a 12-year-old. And now not everyone can do that. And so when we are assessing kids in the schools, that's one of the things we look at. Does this kid need that top tier, that top 1-5% of kids service? Do they need maybe a group once a week where we can serve more kids? Or do they not need service? Is this more of a school? Can we partner with our school to do some training? Maybe we're seeing an increase in kids who are, because they've seen stuff on social media, so they're acting out a certain way in school. Well, maybe that's not mental illness, but maybe we can do some training and some partnership with the school staff on how they can do environmental scans or changes to address that behavior, and everyone gets better. So that would be more of like the bottom tier of the triangle of service.
Yep.
And then we also, our school social workers, they know all the resources in their community. So they really leverage and help us then funnel kids to those community partners, because every community, different resources in New Prague versus Belle Plaine, Jordan, it's very different. So we really look to that school social worker as our conduit to make those connections.
And I figured you may pick up on the whole community partners aspect of this line of questioning. Not questions, but.
And we have programs, I mean, I agree with you. I mean, we don't want to over pathologize, and my staff have heard me say it many times, it doesn't have to be therapy to be therapeutic, and just because it's therapy doesn't mean it's therapeutic. In other words, it's got to be an individualized approach. And we do have partners, Treehouse, I mean, they work with youth, and kids need a sense of belonging, they need validation, they need normal, healthy, fun experiences. And so the more we have that in our community, the more the support they have. And our workers, and Christina can speak to that, we work very hard to create informal supports. Like research shows us, I mean, if a child has another adult that connects with them, makes them feel important, and other than their parent, they do better in life. And so how do we get them connected to grandparents or uncles or who in church, those types of things. So there's a lot of effort put in that direction.
Seems like a great opportunity for community engagement, right? Community engagement, which I know we're super open to, and all those fun things, which is great. I think that was, let me just look quick, my little chicken scratch of those particular questions. I mean, this definitely feels like one of those areas that's calling versus a job versus an assignment, finding that round peg for the round hole to bring about better outcomes and hopefully in efficient ways. So, yes.
This is more a curiosity, and it's probably a little off to the side on the topic, but I'm wondering about threat analysis to health. You know, you would say some health is probably obviously related to biological health issues, and then there's behavioral health issues that are caused by the environment or threats to health. And so I'm wondering where we do a threat analysis of what are the threats to children and youth health, and are those changing? You know, I would say they are changing. I don't want to get political here, but the attitude towards drugs, you know, and legalization of drugs, that's a threat to mental health. And so how will we monitor that? How would we see if it really is or not, and how it's impacting youth? And I know that this is not legal for youth typically, but there's probably a trickle-down effect in what's happening in all of society. So threat analysis to health, I'm curious how we will track that and respond to that.
So as a part of all of our comprehensive evaluations at the Mental Health Center, we do an evaluation of all of those different things. What safety concerns do they have? Are there safety concerns in the home in terms of like abuse, those sorts of things? You know, suicidal ideation, homicidal ideation, all of those things are explored as a part of that comprehensive evaluation. And I would imagine with the case managers as well, there's some conversations around that. So on that level, it's a part of everything we do, is assessing what are the potential threats to this child, and then how can we meet those threats. So in terms of answering when are we doing it, with pretty much every level of intervention that we provide, I can't imagine that it's not happening to assess that.
Yeah, and I can appreciate that and understand on an individualized basis how that might be happening, but how is it happening globally, like in a school? How is a school addressing threat health? It helps the threat kind of to all the kids, or, you know, so forth. Does that come up?
There is.
I was going to say, it's interesting in an environment like this, because I feel like sometimes we have these conversations in isolation, and I've heard, you know, technology, and there's a lot of concern about, you know, is technology leading to the change in kids' mental health? Is it chemicals? Is it drugs? The one part that never gets talked about that I think if we go back to, because this isn't a problem that arose overnight, I don't think it happened during COVID. I think COVID maybe exasperated it a little bit more because of isolation and things. But, you know, every year I have to have a conversation, even at the preschool level, about just let kids play. like we have become so driven in schools, or there was a period of time, I feel like there is a change now because these are conversations we're having in school, but that a lot of people outside of our school conversations aren't privy to. You know, from the early 2000s to the mid 2000s, we were pushing every kid to college. Everybody's got to get a 4-year college degree, every kid. And if I could put my finger on one thing that really has caused a lot of this rise in mental health challenges of our kids, is there's kind of this equilibrium. You're going to have your ups and downs with your friends. You're going to have your ups and downs with your academics. You're going to have your ups and downs with chemical use, with techno. There's all these equilibriums. And when they become out of balance, and I will say from a school educator perspective, we were guilty of that. You know, the whole testing push from the late 90s, early 2000s. I would say now we still do it, but there's probably less pressure, but there's still pressure. Like a kid doesn't do well academically because they're not reading at the level their friend is. That affects their mental health. Like, and we have pushed so much on the academic side when what I've seen firsthand with people I work with whose they were pushing their kids, and now their kid has found a career. They build cars, they make great money at it, they love what they're doing. It doesn't matter at what level they're reading at. It doesn't matter at what level they're doing math at, you know? And so I think what you're kind of getting at is how is this, like we do threat assessments, how is this assessment? I think it's this equilibrium of sometimes it's easy for us to blame technology. Sometimes it's easy for us to blame chemicals. Sometimes we have to look in the mirror and say, all the testing requirements, all of these curricular requirements where we just we're putting curriculum in preschool so kids can't go outside and play. To me, it's ridiculous. Like at some point, it's even developmentally appropriate. So I think that's kind of what you're getting at is my best guess, because what I'm not hearing come up here is our push towards academic curriculum, you know, and it's coming back to the trades a little bit more, but we don't need every single person to get a 4-year college degree. And that was the kick we were on for 15 years.
Mm-hmm. Yeah, for sure. I know, that was impressive. Any last questions? I have one last question, sorry. Page 11, I just wanted to clarify on the out-of-home placement. Our numbers do seem to keep going down, which is great, and we are committed to trying to preserve that family first. And again, just as a indicator only, do we know how we here in our partnership, because I don't want to say here in Scott County, but here in our partnership, how do we rate or compare to other counties or partnerships in some of these? Because we always talk about the Family Resource Center and some of the prevention and diversion things that we are doing that do seem to be working. And again, not in an undermining way, but just to kind of strengthen even maybe perhaps what we're doing. How does that compare? Do we know how that compares with other groups? I don't even want to say a jurisdiction or a county, but because I do feel like this is a partnership. It's not just a county. It's not just a school district. It's not just a, do we have an idea of what, and again, as an indicator, knowing that everyone does it a little bit differently? Because I'm bullish, Suzanne, I'm bullish on this.
I do. I think there's a number of different indicators that we can look at. So we can look at a measure that's called the rate of entry. So per 1,000 kids, what's our rate of entry into out-of-home placement? Scott County, through really probably the last 10 to 20 years, has always been in you can look at it, the top 3 or the bottom 3. So we have one of the lowest. We are either the lowest, second, maybe the third lowest across the state. So I think that speaks to, Steve talked about placement philosophy. We hold that really strong about how do we engage partnerships, both internally and community, to help meet family need. I think you've heard all the panel members speak about when you work with a child, right, you are working with a family system. And the family system is really even beyond mom and dad. It is aunties and uncles and godparents and neighbors. Who is it that we can create a village around to help support a kid and family? So I think it is that. I think we have other sort of anecdotal indicators of many of our county colleagues across the state have had challenges about kids, housing in county buildings or sending kids out of state because of placement need. Knock on wood, we've had certainly challenges, but we've not had those experiences because I think we have a really tight collaboration of partnerships internally and in community to help meet need.
Well, and where I'm coming from, I think everyone is coming from is not doubting that, but finding a way to like really, and I know some of this is newer programs, but really finding ways to strengthen that. So, boy, it's galvanized that, yes, we are getting better outcomes. Guess what? I mean, which in and of itself is a huge win, right? A better outcome, breaking some generational sin, generational trauma, things that are big things, little things, all of that stuff. And it's more efficient. And it's lowering the cost of doing government. I mean, so it's all of these win-win-wins.
Well, and I would even say, and it's better for kids and families.
Of course. That's, I want to go back. That was the number one win, is that the better outcomes is the win.
Right.
All of the other stuff, you get it for free, so to speak. So, all right, that is pretty sure now my last question. Yeah. All right, okay. Moving on, we are going to, yes, thank you so much for this panel. Thank you for this time. It's a very good discussion. So, and perhaps even a little emotional, which is awesome.